So the questions we have are, how do you optimise your imaging for lung scanning, especially for small pneumothoraces? How do you optimise the 4-chamber view in larger patients? How do you assess RV function, and what are pitfalls of scanning for the aorta, and how do you overcome them? So Euan sent in a question, how do you optimise the imaging for lung scanning, particularly those small pneumothoraces? And I've got 6 tips for you. So the first thing we need to consider is what probe you're using. So you can use a curved array. These have got a 60mm footprint. They're 5 to 2 megahertz, and they get 30 centimeters worth of depth penetration. The advantages of that are that they have a wide footprint, and then that lets you see the 2 ribs and lots more sort of space. So you get to see more that's going on and over more than just the 1 rib space. Whereas, and the rib shadow gives you a good landmark for figuring out where your pleural line is. So usually you see more than 1 rib space in between that foot probe. It's got good depth of penetration. So if you're looking for pneumonia and stuff like that, it's really, really good. And it's really good for the lung parenchyma, but it's a bit sort of average for the pleural line. So the disadvantages, that wide footprint can be a help and a hindrance. The lungs can be obscured by the ribs. The poor near-field resolution means that your pleural line is harder to see. So it's not so great for looking for those small pneumothoraces. But if it's the only one you've got, you kind of learn how to overcome that and how to get used to reading the pictures that you get from it. The other sort of probe that you can use is the linear array. This is my my choice pick for pneumothoraxes because it's really good near field resolution. The megahertz range is 15 to 6 or 13 to 6, depending on what systems you're using. And the footprint is quite wide as well, so usually 38 mils or so. The advantage is that wide footprint does let you see the pleural line and a rib, so that you've always got that sort of landmark and anchor with the rib shadow to sort of position where you are and to identify where that pleural line is. The near field resolution is really good, so it does give you better definition of the pleural line. So, and there's good for the pleural space as well. So the disadvantages, the wide footprint can be a help and a hindrance, but it's obscured. That means the lung can obscure the ribs. It's got limited depth penetration. So if you are looking for pneumonia and B lines, this isn't the probe to use. You need to get enough depth penetration to be able to see those B lines go all the way through the screen. So it's not good for the lung parenchyma. So here we've got pictures of the same patient with a curved probe, and if we look at the sort of white line here, that's the pleural line. And then exactly again, the how do I put you guys up here so you can see? Are you all getting obscured with your faces in the road here? Hang on. Let's go there. All right, so here's the linear. The linear is the same to see the pleural line here, so you get better resolution at that pleural surface. The next thing you can try is try an abdo preset instead of the lung. On some machines, they have a lung preset, but if you haven't got a lung preset, just try it with an abdo preset. But what you will need to do is turn off your tissue harmonics imaging and compound imaging. Tissue harmonics imaging, essentially what happens here, it's a way for the machine to filter out some noise and stuff. So when you're doing things other than lung, it's great because it filters out a lot of stuff that you don't want. But so the principle here is that you send out the ultrasound beam at a certain frequency, and then you only listen for the harmonic frequency, which usually occurs in multiples of that fundamental frequency. So if you send out at 3, you're going to be listening at 6, and all the other frequencies get dropped. So then it filters out quite a lot of information, which in other regions is really good, but for lung ultrasound, when we're relying on interpreting the artifacts, we don't want to get rid of them. So here's an example of, on the left, with tissue harmonics off. Oops. And then the image on the right with tissue harmonics on. So it's sort of, you can see that there's more artifact to be seen over here, whereas it's filtered out on this image. So if you're looking for lung sliding, you don't want to get rid of that artifact. The other one is compound imaging, and what happens here is that the machines use beam steering to point the ultrasound beam at multiple different angles, and where they overlap, they represent that image and pretty much dump the rest. So again, it filters out a lot of noise, but for lung imaging, that's not what we want to do. So we have no compounding on the right, on the left, and on the right, we've got the compound imaging turned on, and you can see this rawer picture on the left here. You can see more of the artifact. Some of these higher end machines though, you still see the lung sliding. It just makes your job easier, and certainly for your more difficult patients, you want all the odds stacked in your favour. The other thing to think about for those small pneumothoraces is to make sure your depth settings are correct. So if you've got your depth set, as we have on the left here at 15 centimetres, that's great for the B lines. But if you're concentrating on the pleural line looking for a pneumothorax, what's happening here is that your focal zone is sort of sitting somewhere depth. You bring your focal zone up to where the pleural line is, and then you get better definition. And I think the last one that we want to talk about is just making sure that your probe is perpendicular to the lung. So make sure that you try to, you rock your probe so that the pleural line is horizontal on the reflection that you can. So we have an image here where the pleural line is perpendicular to the probe face. And on the right, just when we've rocked our probe a little bit, you can still see the slides at the moment. My 14-year-old daughter, who is way fit, so she makes lovely pictures no matter what she does. But you know, your larger patients, if you do rock your probe and make sure that your probe face is perpendicular to the lung surface, you'll get a better picture because of it. So the 6 tips there for you were choose the right probe, which my preference for pneumothorax would be the linear probe. Make sure you've got the machine, choose that one. Otherwise, if you don't have the option of a lung preset, try the abdo preset, and then turn off the tissue harmonic and turn off so that you're looking at the area of interest. So bring your depth up to 4 to 5 centimetres, depending on how big your patient is. And then make sure your probe is perpendicular to the chest wall. So does anyone have any questions at this point before we move on to our next question?
I guess I got colleagues who have kind of mixed opinions about using. I've got colleagues who have mixed opinions about using M mode for lung ultrasound when looking for pneumothoraces, and I just wondered if you guys had strong feelings on using M mode to increase sensitivity at picking up those small pneumothoraces, where sometimes looking at the actual image can be a bit tricky to see the lung sliding or not.
The M mode is nice if you don't know how to save a loop. It's a nice way to demonstrate over time movement of one spot. So I think I've got some more people coming in here, but I just don't know how to get to them. Anyway, so if you maybe I'll go this way. No, there we are. We always teach it. I haven't seen enough of the tiny pneumothoraces to know what the clinical sensitivity is, whether if it increases it or not, but it's a good way to demonstrate over time or just to double check and make sure. Does anyone else have any thoughts on that and what they do in their department? No? All right, any other questions on lung there? Rebecca, what do you guys routinely use lung, use the M mode for lung? Do you do much lung scanning? Can everyone hear me okay? Yeah, good. Well, there you go.
Yes.
Hi, Rebecca.
Hi, yeah. No, we mainly do loops. I think M mode mainly if you're having trouble doing a loop, or if some of the juniors like it better because they are then more sure that there is or isn't lung sliding. So a few people do both, but most people just do loops.
I know when I'm reviewing people's images, I like to see a loop. I think it helps. It helps you be able to see that there's actually real lung sliding. And even then, on some of the patients that are really, really short of breath, it's really hard to tell. I know that when lung ultrasound sort of first hit popularity stakes, M mode was very popular, and I've heard much more that it is. You know, do you need to? Probably not. If you've got a really good loop and you can see the lung sliding. But it's a way, it's like when we're doing a fetal heart trace, you know, as the operator, you look at the fetal heart trace and you can see that it's beating, but you need to prove to the outside world that it's beating. So the M mode provides a way to demonstrate a passage of time in one photo. And certainly in radiology circumstances, you know, we didn't take as many loops there, so the M mode was great. Whereas I think the point of care systems make it much easier to be able to take a short loop to show that that lung is sliding and there is movement.
Yeah, I think if you see the lung sliding, then that, like my practice has been, that's fine. But then if you, like I use the M mode as a kind of belt and braces if I don't think there's lung sliding, just as something extra, an extra data point to kind of back that up further, you know, which is, I guess, the point that you're alluding to.
Well, and the other thing I'd say about that is you don't want to just, if you're going to use M mode and you want to rely on that as a backstop, as with anything, when you're doing it, you need to practice it all the time so that on those cases where you really aren't sure, it's actually helpful to you. If you only ever practice it on the cases that are difficult, then you don't build your confidence at reading those pictures. So if it's something that you find can be helpful for the smaller ones, it would be that you need to practice it for each time so you get used to the button pushing, you can do it reliably, and you get confidence in how you are interpreting that picture. You know, I think it's hard to just pull out the tricks of the trade only when it's a difficult patient, because you haven't actually developed the skills in a reliable way to start with. So, you know, if you're going, cool. All right, well, we might move on to the next question. So Andy, hi Andy, I saw you join the call somewhere there. Are you there? Andy asked, how do you optimize the 4-chamber view in a larger patient? And larger patients are always going to produce, especially for heart scanning, it's always really hard to get a nice picture. So the first point that I'd talk to is what frequency of, what's the frequency of your probe? So you've got your phased array probe, but also on not necessarily the handhelds, but a lot of the more sophisticated systems let you play with the frequency range within that probe. So if you think about high frequency, you get really nice resolution near the surface, but get 6 to 10 centimetres into the patient. And they're like your sprint runners. Whereas your lower frequency probes, you curve, but in particular for heart, because of the small footprint and it can fit between the ribs, they're 1 to 5 megahertz. These guys are like, so if you're on a on Philips or Sonosite equipment, tend to have the terminology res, gen and pen, or variations. So frequency choice and is good for your thinner patients. General is right back in the middle, and that's what will come up as the default when you choose your preset, and that's designed for average Joe. And then penetration setting is the one that you need to use for your larger patients because it's a lower frequency setting. So on other types of equipment that have the sort of defined frequency, they actually, you turn the knob and you can actually choose the frequency, the specific frequency. So the resolution's more on that 5 to 1 megahertz probe is more of 5 megahertz, and your penetration's more of your 2 megahertz. So for your larger patients, straight away dropping the frequency means that, especially for that subcostal view, you've got to get through some liver tissue, and the heart is actually, or the top side of the heart is actually quite a distance away from the probe. So if you dial your frequency down, it's like turning on the lights in the far field. The next tip I'd say, for most of your thinner patients, you'd pop your probe on in the midline here. And for most patients, you point the probe to the chin. The heart is left-sided, but in the normal heart spends a lot of time right in the middle. Sometimes you just need to point that slightly to the left side of the chin. But in your larger patients, what you might need to do is move your probe a little bit to their right so that you put more liver between you and the heart, and you take advantage of the liver as a window. So the other thing is just play with the tilt on your probe in this direction to try to figure out where is that longer view, that where you can see the heart the best. That the angle of the probe at this point is quite variable for lots of different people, and sometimes it can even be quite flat on the stomach almost. There's always for the apical 4, roll your patient that are sitting just up on the edge of the rib and trying to maximise how big that rib space is. The last but not least thing to do is to get your muscles into it, bend your patient closer and minimise the distance that the beam has to travel. Does anyone else have any tips they'd like to share or comments to make or questions on that one?
So I think Euan, can you hear me, Euan?
Yeah, I can. Thanks, Anthony.
Sure. Definitely for a 4-chamber view, don't underestimate, if you can, asking your patient to take a big breath in or big breath out. I sort of have 3 rules about breathing when it comes to cardiac. The parasternal long is usually an out. The subcostal view is usually an in. And the apical 4 is one or the other. Don't forget that. And then also, sometimes you just have to accept an off-axis image and a foreshortened image, because that's just what you're going to get. Even as and I'm a cardiac sonographer, and I'll put my hand up here that I'll be standing over a student's shoulder, and I'll say, just take it, because that's what you've got. Sometimes near enough is close enough. We should always strive for the best, but especially in the ED or an ICU scenario where A, you don't have a cutout on the bed, and B, you're time poor, sometimes close enough is good enough. But go low and lateral, start low and lateral, sweep the intercostal space up, and then if you can't find anything, go back low and lateral, jump in intercostal space north, sweep it, go back, jump, jump, jump. Don't be a plonker. Don't accept that first plonk that you see when you put your probe down.
And I think I've just learned a new term. I like this, plonker. Does anyone else have any comments or questions there?
I want to know what Euan's partaking in.
I'm going to plead the fifth on that one. My defense is it's 10 p.m. in New Zealand, so
Enjoy.
Andrew, does that answer the question that you had?
Yes, thanks, Euan. That's great. And Anthony, thank you very much.
Cool.
Andy.
Cool. All right. Well, I'll move on to the next question. This was a popular one. Both Andy, Euan and Rebecca asked, how do you assess RV function? And I guess it's probably a little bit topical given the sort of heart signs and stuff we're seeing with COVID and blood clots and stuff. So the first thing I want to just talk about is just how do you assess a normal heart, and what is normal about the heart. So there's sort of three views that are going to help you assess that right ventricle. If we look at the parasternal long view and looking at the rule of thirds, in that parasternal long, the right outflow tract, the aorta, and the left atrium are all even. So they're all about 1/3, 1/3, 1/3.
Suanna,
If we look
be
at
sharing
the
your screen.
apical, oh yeah, thanks, Anthony. Where did it go? Hang on. Now I've got you all down here, and I want to make this.
Cool.
There we are. It's finding where to put things so that you can still see all the slide. Sorry about that. We'll go here in the parasternal, the 1/3, 1/3, 1/3. So the right outflow tract, the aorta, and the left atrium are roughly even in size. In your apical four-chamber view, your atria represent about 1/3 of the length of the heart, and your ventricles are 2/3 of the length of the heart. The other thing to look for is these pointy ends of the ventricles in that apical view. If they're starting to round out, is your view foreshortened, or have you, or is it because there's some right ventricular dilatation? Also in the apical four-chamber view, the right side here is about 0.6:1 ratio. So the right ventricle is about 1/3 narrower than the left ventricle. So if we look at acutely elevated right ventricular pressures, there's 5 things for us to look at over those 3 views. The first thing we're looking at is a large, I think that should say a large RV, sorry about that. So a large RV, an underfilled left ventricle, looking for paradoxical septal wall motion, or the D sign. I've also heard this described as the OD sign. So when your right ventricle is really big, it's an O, and the left ventricle makes the D. Looking to see which ventricle is more dominant at the apex, and when you've got elevated right ventricular pressures, the right ventricle, last but not least, is McConnell sign. So let's have a look at the parasternal long axis. This is normal to start with. So if we look here and have a look at the right outflow tract, the aorta, and the left atrium, it follows that 1/3, 1/3, 1/3 sort of principles. When it's enlarged, you have a large right ventricle and an underfilled LV, and you can see both of those on the parasternal long axis view. So we can see here a large right ventricle, and the left ventricle is a little bit underfilled here. In the parasternal short axis view, we're looking for the D sign and D sort of shape of the left ventricle and paradoxical septal wall motion. So here is normal. We've got nice round ventricle and a good RV here. And in the, you can also see on that parasternal short axis view, dilated right ventricle. So this is normal, and you've got this sort of crescent shaped right ventricle there. And when the pressures are elevated, the right ventricle then blows up and is quite round and looks like an O, while the left ventricle looks like a D. So on this clip, you can see a really large right ventricle up here, and we can also see that D-shaped left ventricle with the septum going all weird because of the pressures that are all out of balance. On the apical four-chamber view, we're looking at how this part, where the valves are, how much that sort of goes up and down, and we're also looking at which ventricle takes up the most part of the apex. So if we have a look here on, this is normal, you can see on this one, the left ventricle occupies most of the area of the apex of the heart there, and not so much on the right. When the right heart is dilated, then now here we've got a case where the right ventricle is taking up the apex, and this is a severe case of dilatation, but the right ventricle is taking up more of the apex, and the left ventricle there is smaller. The last one is McConnell's sign, and this is where you have the hypokinetic ventricular wall, but you preserve the contractility of the apex here. So you can see not much movement happening here, but the apex still contracts normally. And this is another example where you can see some contractility here, but not as much squeeze coming on in here. And this one also has a little bit of scary stuff ready to go just in there. One of the measurements Rebecca asked about, and there were two, there was the TAPSE measurement and the RIMP. I'm going to plead the fifth on the RIMP. I'd never heard of it until you'd sent it, but I'll see if Anthony can jump in. I haven't heard of RIMP being used in point of care circles, and I'd have to say I think that's more, if you're going to do that level of measurements, it's more for a formal cardiac scan rather than the point of care scan. But the TAPSE measurement is the measurement of the tricuspid annular plane systolic excursion. And if it's more than 16 millimeters, everything's fine. And if it's less, then it's representing right dysfunction. So essentially, as the heart contracts, you get rise of the base of the heart here. So the tricuspid annulus contracts up in systole, and then you get descent of the base in diastole. So if you look at this normal heart and look at what's happening here, where the valves are sitting, you can see that they're moving up and down quite vigorously. So we're looking at this line here and watching how much that tricuspid annulus moves up and down to tell us whether that heart is still beating well. So then you pop on the, once you get a really good four-chamber, or the best four-chamber view that you can get, you pop the M mode cursor and move it so that it intersects the tricuspid annulus at the lateral ventricular wall. And then what you see on your M mode there is movement of the tricuspid valve level. And up here, you'll get a bit of wriggling as well, and that's movement of the ventricular wall right at the apex there. So then all you need to do is measure from the valley to the peak, and that measurement should be more than 16 millimeters, which indicates normal. If it's less than 16 millimeters, it's a sign of right heart failure, but it's not necessarily specific for a saddle embolus. It can mean you can have right ventricular failure or an infarction of the right ventricular wall, which will affect this measurement. So it's an abnormal TAPSE measurement doesn't mean that it's absolutely one, and it's not specifically saying that there's a saddle embolus here. There's more reasons why the right ventricles might not work. So the other question was, what's RIMP? Another typo here. Anyway, the right ventricular index of myocardial performance. Like I said, I'd never heard of it before. But I'm not an echo tech, I'm a general trained sonographer. So I was wondering, and Anthony, do you use this? Do you know of anyone using this in a point of care sort of fashion? What's your thoughts on RIMP?
Yes, and I'll be honest, I've never done a RIMP, not in the point of care nor the actual formal scanning environment. We measure elements of the RIMP, and I guess for those of you who don't sort of, who've never heard of the measurement, it's specifically got to do with the timing of the ejection phase versus the isovolumetric contraction time and relaxation times divided by the ejection time. So you're essentially measuring Doppler from a TAPSE, and you're or using Doppler through the valve itself to come up with these indices. And I think it's just fraught with measurement issues. I've got a feeling that unless you've actually got the time and the inclination to do really spot on top scanning, then in the point of care environment, I don't know if you've actually got the time, the patience, or the inclination to do it. I would much rather see you doing a really good TAPSE. And TAPSE, I'm a big fan of TAPSE. And if it's done well, it's really good. I guess the caveats around TAPSE is that, remember, it's just the longitudinal function that you're looking at. You're not actually also then having a look at the rotational function, and that's where the parasternal long axis comes in. I mean, I can go into the origins of RIMP, or not necessarily the origins, but on how to do it. But it's quite an advanced measurement. As I said, in our general cardiology practice, we don't do it. And to be honest, I know that there's an abnormal cutoff, but what it actually means, I don't know.
With the TAPSE, if the patient has like a concurrent underlying tricuspid valvulopathy, do you run into pitfalls with that where you maybe get, relative to normal tricuspid valve, you might get a false positive or a false negative?
I guess the primary issue with a tricuspid valve abnormality is that you're probably going to get dilatation of the tricuspid annulus. So yes, I do believe that you will probably get, and what it is probably a reduction in TAPSE, so an abnormally low TAPSE. So it comes back to that standard thing, whether it's cardiac echo, general echo, lungs, whatever, you've got to do multiple views of your thing that you're imaging. And if you see that in the parasternal long axis, the contraction is good, but in the parasternal, in the apical 4, it's down. But then when you go to the subcostal view, which I think is one of the best views to look at right ventricular function, if the right ventricle looks good, then I don't hang my hat so much on the TAPSE. And there are just those times I've looked at TAPSE and I thought, why is it so low? An angle of measurement, all those types of weird things that can occur.
Thanks.
Rebecca, does that answer the question that you had?
Yes, that was good.
Oh, cool.
Well done, Euan.
All right. Again, I'm a general sonographer, so I've got very limited echo, but it's point of care echo skills. rather than the full length. So thanks, Anthony. That was a great help. Now, the last question that we had that had been sent in before I can kind of open it up to the floor is, or the cloud perhaps is what we should be saying, is Euan also sent in, what are the pitfalls when you're scanning the aorta and how do you avoid them? So the common mistakes that I've seen people make, certainly as they're learning, but I imagine that would be amplified when it's all in the heat of the moment and you're worried about a big aneurysm, is getting their depth settings wrong. So the first way that you can get this wrong is to have your depth set way too deep. And this is a really common one because for some reason people sort of choose the preset and then whatever it's set on, it's just left there. And so, you know, when you come in and you've got your depth set at 30 centimeters or whatever, it's very easy to look at this vertebral shadow and think that that's the aorta with some calcific edges. And especially if you have to go fast or you're, you know, you're not sure what you're looking at. I've seen many of our students have done this and have sort of measured that vertebral body. I've even heard of a case that this happened. They went to theatre, were opened up, and then they realised it's a completely normal aorta. So it's a really big mistake that you can make. And so when I'm teaching this practically, I always suggest that people don't look for the aorta first. Have a look and find your vertebral body and identify your vertebral body first. Because once you've got your vertebral body, you know your aorta is sitting anterior to that. So here's where we've corrected it. Here's way too deep, obviously. And by the time we come over to a more appropriate depth setting, we've got our vertebral body shadow here with the aorta sitting just in front of it. The other way that I've seen this goes wrong is people, again, the machine's on whatever the last person left it on and you're scared to tweak the buttons or forget to or don't have time to, and set the depth way too shallow and then, you know, cut off the aorta and so carry on measuring this here, which is the superior mesenteric artery. So, and this one's pulsatile at least, and so it's easy to sort of make the mistake. But again, it comes back to when you're first scanning, wherever in the softer part of the belly, pop the probe on, find your vertebral body first as the landmark for the window, and then adjust your depth so that you can see where the aorta is. The other advantage for doing that, if you run up and down the belly in transverse, you know, if the aorta, as you scan north and south, is dancing all over the screen, it tells me that there's a tortuous aorta. But if it's sort of sticking in the same place and is very consistently sitting on that anterior surface of the vertebral body there, then you know that there's not so much tortuosity. The next mistake that can be made is when you're scanning in longitudinal, to be able to see the proximal part of the aorta, you need to be tilting your probe up or pointing the crystals sort of up under the rib cage to get proximally here. And then what happens is you've got the aorta on this angle. And so you have to, at the beginning of that longitudinal scan, start quite high and visualize that proximal portion to sort of identify where your celiac trunk and your superior mesenteric artery are coming. But after you've examined that and excluded an aneurysm quite high up and proximal to the diaphragm, then you need to rock the probe so that your aorta is going across the screen as horizontally as you can. And the reason for this is when you have a dissectional flap, they're it's a very, very thin layer of material, and you need to be perfectly at 90 degrees to get any sound returning from that dissectional flap. So if you've got your aorta like this one on the left and it's still quite oblique, you can miss a dissectional flap. So make sure after you've examined that proximal part that you then rock the probe so that your aorta goes much more horizontally on the screen and that your crystals are then intersecting that aorta at 90 degrees so that you get the best specular reflection possible from a potential dissectional flap. The other one is, I see a lot of people sort of just put the probe on and point it perpendicular to the bed, and then they just miss, they completely miss 5 to 7, 8 centimetres proximally. So you need to make sure that you, in longitudinal, you bring that probe hard up against the xiphisternum and then point the crystals up underneath the xiphisternum so that you do see the aorta up to the diaphragm. The other big problem, and this is the one on those patients that you really need to see their aorta, this is always going to be the hardest bit. So you can see in this picture, oops, hang on, I'm just going to move this over here for a sec. You can see aorta here, and then it's kind of obscured just on the edge here by this bowel gas, which I'm going to bring that little bowel gas cloud back in, and the aorta there. So what you can do, and that's if you're sitting right on top of the aorta. So what you can do here is to just slide your probe away from the bowel gas. So if the bowel gas is on, oops, bring that up here. If the bowel gas is on the patient's left there, if I just move my probe, you know, 3 or 4 centimetres perhaps, and sometimes it's not even that far, just slide it over to away from the bowel gas and then point back in the direction that you come, then you can sort of separate your aorta here and get much clearer visualisation of the aorta. So the things that we've looked at is the depth settings are really, really important. And I think this is the most common mistake I see people make, is to forget to adjust the depth and also the gain. The gain can help as well. If you overgain it and everything's too bright, you'll fill things in that aren't there. But if it's too dark, you won't see what you need to. So if you do suspect that there is an aneurysm, try to set your gain up nicely, but then wind it up so you might be able to see the thrombus in the wall as well. You can miss a dissectional flap if you're not perpendicular to the aorta, and if you don't scan proximal enough, there is a whole big chunk of the aorta that you're missing. The other thing you can do is very gently push harder, firm graded compression to either squash that bowel gas and squash that loop of bowel so the gas moves along to the next bit, or just adjust your window and move away from the gas and sort of point your sound behind where the gas is. Sometimes that is really hard because, especially transverse colon, it obscures quite a big bit. So I always suggest people find the aorta first in the soft part of the belly, identify the vertebral body as the landmark, then move the probe in that transverse all the way up to xiphisternum, and then count to 10 as you sweep down from proximal to distal, and keep moving the probe, because what I see happen is you get to a bit of bowel gas, you lose the aorta, and then you're just completely lost. And, you know, it doesn't matter how long you sit there on that transverse colon, the bowel gas is going to be there. Whereas if you keep moving the probe, you'll see the aorta sort of pop out again from behind the bowel gas. There are times where there are segments of aorta that you are just not going to see with an anterior approach. You can try a coronal window. So come in like you would for the right upper quadrant or left upper quadrant view for your fast scan, set your depth a bit deeper and have a look from the coronal window. The aorta. Does anyone have any other suggestions? Or, I don't want to do that. Here we are. Does any, Daniela, is there anything else you do when you're going after an aorta, a stubborn aorta?
If the patient's really large, I don't know whether they have the option of lowering the bed down, but you can use your gravity and weight push down. Sometimes it's really hard to push down if they've got a big tummy and you're up high, your arms are high.
Yeah.
Knees up to relax the tummy, if you can do that, or pillow under the knees to relax the belly a little bit. That works for subcostal 4 heart as well. Coming laterally on either side and, like you said, rocking in if there's bowel gas in the way. Yeah.
Does anyone have any other questions on the aorta? Does that answer the question, Euan?
Yeah, I think it's like anything. It's within easy subjects are easy to get pretty good pictures, and it's the the bigger people or the people with lots of bile gas that are tricky, and sometimes no matter what you do, it's very difficult to get optimal bedside imaging, especially when you're time pressured. I think the other thing that I've seen, like I've done personally, certainly in the past, and I've seen other people do as well, is identify IVC sometimes instead of aorta.
Yes.
And kind of like using the seagull sign and stuff as, an initial approach to make sure that, is this venous or is this aorta, first of all?
You can also, if you compress and push on the IVC, it'll collapse, whereas the aorta doesn't collapse unless you've missed something rather a lot larger problem. So, is there anything else that you try, Rebecca? Unmute.
We had a cracking case actually over the last couple of days where a gentleman came into one of our EDs with a non-STEMI, back pain, etc., etc. He had a point of care which measured the aorta slightly. Now, I don't do much below the diaphragm. So he measured the aorta, but very much below the subcostal space, and it was actually normal. Went for his left heart cath, had a stent done for some disease, and then developed chest pain again was having his pre-discharge echo. And the sonographer who was doing the scan is a dual-trained pediatric sonographer. And his habit is to always check the abdominal aorta as well from the subcostal window. And because we're cardiac sonographers, we're right up there into the subcostal window. And he rocked down to have a look at the aorta, and there's this massive flap sitting there with a very nicely dilated AAA. And obviously, we don't know what came first, the cath or the dissection. We think that the dissection came after the cath, but the bottom line is the AAA was missed when the POCUS scan was done, and then it was a type B dissection. I don't know what they've done with him. It's still an ongoing case. I mean, he's still actually with us, but I guess that's a point that you made there, Euan, is go high, because that was missed when. I don't know if it would have changed his outcome or whatever. I have no idea. But the bottom line is a proper type AAA was missed because it was a low down image.
Cool. Thanks, Anthony. And we've got about 5 minutes left, so we can either all sit here and compare notes about something and have a bit of a chat, or has anyone got any specific off-the-cuff questions that they wanted to ask at all?
I guess my echo skills are pretty primitive. From those who have more advanced echo skills, when you're looking at, like we talked about, say a saddle embolism, someone comes in who you suspect PE, and you're looking for right ventricular hypertrophy or right heart strain. Of the points we talked about, does anyone have kind of anecdotal opinion on what is the most sensitive, or what is the most common to pitfall and which is the most reliable of the kind of 5 or 6 that we talked about? Comparing like the D sign and McConnell's, and comparing the actual thirds rule and stuff.
I might ask Anthony, do you have any thoughts on that?
Yeah, sure. I'll be a bit tongue in cheek and say the best thing is the CT scanner, but no, I won't. No. Okay, so McConnell's. Be careful of McConnell's. There are other pathologies that can create McConnell's. So that's number one. Dilatation post-cardiac arrest, you will get a dilated RV, especially if it's a prolonged resuscitation. Obviously, if there's free-floating thrombus, bonza. In 24, I can't actually, maybe it's 25 years of scanning, I have yet to actually find a saddle PE, okay, on echo, which is really frustrating because I've had a couple of students do it after like their first 2 months. So it really irritates me. That's how rare it is, I guess. Then the TAPSI and the 60-60, yep, I like that. I don't mind that at all. But I guess I take it that if it smells like and looks like and there's a couple echo features of it, then it probably is. I definitely would not hang my hat on, and you know this, you wouldn't hang your hat on one modality or one part of the modality. So, you know, you just got to go hunting, and you're the clinicians, you have that brilliant clinical nous that gives you that ability to work out, okay, this person's got a PE, even though there may be subtle changes. And I guess the problem as well is that you really need a big PE to have those massive changes, don't you? And it's very frustrating for that subtle change or the small non-massive obstructive PE, and you really don't want to send the person through the scanner because their kidneys are off or whatever it is.
I suppose the main utility is like the scenario is when someone is so clapped out, you know, shocked that, you know, you think, okay, they're not fit to go through the scanner and they're peri-arrest, and do we thrombolyze or not based on an echo? And I suppose actually thinking about it, in those scenarios, you're always going to have, you would hope, pretty obvious echo signs. It's not going to be the little changes where you're thinking, oh, is this quite right or not? You know, those might be present in a segmental PE or something. But am I right in thinking if you're in a scenario where, you know, they have a saddle embolism that's causing them to be peri-arrest, you're going to have pretty black and white signs as opposed to grey areas?
Yeah, I think obviously the larger the PE, in my personal experience, the larger the PE, the more obvious the signs are. I can think of one case where a person came in with what turned out to be a massive PE, and a confusing factor was that they actually did have pulmonary hypertension as well. So they already had a dilated right heart. They already had a hypertrophied right heart, which you don't get with a PE, okay, unless it's a chronic type of scenario. And now they've come in with a collapse and everything else. And it was decided in the end that they were going to palliate this person anyway. But we managed to actually see a thrombus before the decision was made to palliate the person. So if it really is that first time presentation PE and it's massive enough, as you quite rightly said, Euan, and they're that clapped out and done for, then there will be visible signs. And hopefully you'll also get a good story from hopefully bystanders or family.
Yeah. Thanks.
Well, crew, we're coming up on the 1 hour mark here. So the intention of this, as I said, is to be a forum for people to chat about, to send in questions, to share tips and tricks with each other, but also as a support network, because I know once you're out there in the field, sometimes it's hard to get some help with just some simple things. I mean, they're simple to us because we're doing ultrasound all the time, but if there's not someone standing there. So if you have any of those sorts of questions and you want to send them in, please do so. It'll be the same bat time and same bat station next week. And I'm going to take this opportunity again to say thank you to our sponsors and supporters of Philips. Make that small, at Philips Ultrasound. I've been playing with the Lumify at home here, locked down in isolation, and it's such a cool little system. Really, really nice imaging of it. So if anyone's got any questions about that or questions you want to send in for next week, feel free to spread the word that this is going on. Our Twitter handle is at Zedu now, and my personal Twitter handle is at I_C_sound. So otherwise, it'll be good to see you folks next week.